Hi, this is Dr. Nader Paksima. I'm a professor of orthopedic surgery here at NYU, and my model today is Eileen Gavina. So today's goal is to take a look at a typical elbow exam, and we'll go through a systematic approach to the elbow examination, and I'll talk you through all of the important points. So thanks, Eileen. So when examining a patient, after I've taken the history, I like to move on to the physical exam, and the physical exam typically starts with observation. So in observation, it's always important to make sure you can see both elbows. So here Eileen has rolled up her sleeve so that we can clearly see both elbows. And I'm looking for any asymmetry, if there's any swelling, if there's any ecchymosis, signs of infection such as redness. I'll look at the back of the elbow to look for the olecranon bursa to see if there's any bursitis. And you want to look at the front of the elbow to make sure the normal antecubital contour is there. If there's any vascular abnormalities, or anything at all on observation. You can pick up a lot of things on observation. So after observation, the next step is checking the range of motion. And range of motion has sort of two components in my mind, active and passive range of motion. So let's start with the active range of motion. So in my typical examination, I'll ask the patient to raise hands above the arm, both arms above the head, behind the neck, behind the back, stretch your arms out, and bend both elbows. So with those maneuvers, basically we're looking at the gross range of motion of the shoulder and elbow. And I like to watch both arms at the same time because that gives me a sense of how easy the patient moves their upper extremity, the speed at which they move, if there's any part of the motion that they get hung up on, does it catch at one point, and so forth. And although we're concentrating on the elbow today, a quick shoulder exam, like I just did, is also an important component of the elbow exam to make sure that the shoulder is not the point of pathology. So that's your active range of motion. Now, a quick word about range of motion of the elbow. So by convention, the range of motion of the elbow, we define this as 0, and this would be, I'd say, about 135. So extension is the first number, and flexion would be the second number. So if I say somebody's elbow range of motion is from 10 to 120, that means that they have a 10-degree extension deficit and they can flex to about 120 degrees. So that's the convention. So now some people have hyperextension of the elbow, and their elbow will go, and maybe has about 5 degrees of hyperextension. So the elbow can hyperextend. So in those cases, the way I report that is with a plus sign. So if I write on the chart plus 10 to 135, that means 10 degrees of hyperextension to 135 degrees of flexion. Now, we always want to check the active range of motion that the patient can do on their own, and then the passive range of motion to see if there's a difference. So if actively they can only flex to, let's say, 90 degrees, but passively you can get to 110 degrees, that's important information. And that could become important in post-traumatic cases where there's contracture and scar tissue and things like that. In general, if there's a difference between active and passive motion, that means that the joint has more motion than the tendons can move it through. So if we're thinking about a problem with loss of range of motion from a tendon problem, then typically there's more passive range of motion than active range of motion. Don't forget that the elbow has the flexion extension component, but also the forearm rotation also happens at the elbow at the PRUJ. So let's go over the range of motion measurements for forearm rotation. So I'll ask the patient to have their arms out like this, and they can turn palms up, supination, and palms down, pronation. So typically, most people have about 80 to 85 degrees in either direction, and by checking both simultaneously, you can see very easily if there's a difference. So now here's a goniometer, and when we're measuring range of motion, it's always important to use a goniometer to be accurate. So for example, earlier, I looked at the elbow range of motion, and so you can see here, you want to put the hinge right at the hinge of the elbow motion, and then, this would be 0, and Eileen gets to about 5 degrees of hyperextension. And then please flex your elbow. And so here, when we have the flexion, again, the hinge corresponds to the hinge of the elbow, and then you measure the range of motion. And she's 135, like we guesstimated. Now, when it comes to forearm rotation, it's more difficult. But one trick is you can use one limb of the goniometer in line with the forearm, and then line up the other one with the humerus, and then you can take a look and see. But as you can see, there's a lot of variability with measuring forearm rotation. So that's always a challenge, but as long as you do it consistently the same way every time, then your notes will match. And always comparing the left and right sides is very helpful. So now that we've checked the range of motion and flexion extension, as well as pronation and supination, we're going to move on to some more specific tests. So let's look at some landmarks, and maybe we can zoom in on this aspect of the elbow just for a second. So some typical landmarks are the tip of the olecranon. So this is the tip of the olecranon process. And remember that the olecranon is important for two things. The triceps inserts onto this area, and you can get olecranon bursitis. So if you have a sac of fluid here, with or without infection, that's olecranon bursitis. Now, from the olecranon, if we go up a little bit, we'll feel a point on the distal humerus, and that's the lateral epicondyle. So that's the tip of the olecranon. This is the lateral epicondyle, and this is the site that will be tender in lateral epicondylitis or tennis elbow. So we want to be able to palpate from the olecranon to the lateral epicondyle, and then just moving distal a little bit, we'll get to the radiocapitellar joint. And the best way to tell that is by rotating the forearm, and you can actually feel the radial head moving under your thumb. So the difference between lateral epicondyle and radiocapitellar joint is only about 5 millimeters. So these structures are close, but you can use the rotation of the forearm to differentiate between the two. Between the olecranon, lateral epicondyle, and the shaft of the ulna, there's a muscle here called the anconeus muscle. It's a triangular shaped muscle. And so you can kind of feel there's a little squishy part of the elbow right here. And that part is the anconeus muscle that corresponds to the anconeus muscle. You can always test that by asking the patient to make a fist, and that tightens up that muscle a little bit because it's involved in stabilizing the elbow. So that's the anconeus muscle, and that's an important landmark whenever you need to stick a needle in the elbow joint. So if you're looking to stick a needle in the elbow joint to do an aspiration of a hematoma or to inject into cortisone or something into the elbow joint itself, it's those 3 points make up a triangle which corresponds to the anconeus, and you would shoot right through it. So now further up on the arm, we have the lateral epicondyle, and then if you keep going in a cephalad direction, you feel that there's a sharp piece of bone here, and you can fall posterior or anterior to it, posterior or anterior to it. And that's the supracondylar ridge, the supracondylar ridge. So that corresponds to the supracondylar ridge, and that's an important part to feel because the common extensor tendon attaches to the lateral epicondyle, but there's also some extensions of the mobile wad muscles to the supracondylar ridge. These muscles right here are considered the mobile wad. So it's this muscle group right over here. And the mobile wad, you can palpate it, you can pinch it in your hand and feel the muscles of the mobile wad, which is the brachioradialis and the ECRL and ECRB. So why is this useful? Well, if you want to differentiate between tennis elbow pain, which would be right over the lateral epicondyle, and radial tunnel pain, which would be about 3 centimeters more distal, right at the mobile wad in this area, that's how you find it. Remember that in this area, there's a muscle called the supinator, and the radial nerve comes down the arm and it goes like this, in this direction, right through the supinator, and that's where radial tunnel syndrome occurs. So you want to differentiate between lateral epicondylitis pain, right over the bone, versus radial tunnel pain, which is a little further distal. Now, if you want to make the mobile wad stand up a little bit, you can ask the patient to do a hammer curl. So we're going to make a tight fist and keep the forearm in neutral rotation, and I'll push down, and Eileen's going to resist, and you can see the muscles right here contracting. So that's how you differentiate the mobile wad muscles. And the anconeus we talked about, and this is the olecranon and the triceps. If you want to test the triceps strength, you would test by pushing, and here Eileen is demonstrating her triceps. It's a nice separation of the lateral head of the triceps. Good job. And of course, there's lots of muscles that flex the elbow. So when we test elbow flexion, here we're going to test elbow flexion. Go ahead and bend your elbow. So we're testing elbow flexion. You can see that brachioradialis is involved here. The biceps is involved here. The brachialis is involved here. So that's elbow flexion. Now, from the tip of the olecranon, we can feel the shaft of the ulna. We've already found the radial head, and we found the humerus with the supracondylar ridge. If you keep going north, if you keep going cephalad from the lateral epicondyle, about 10 centimeters up, you're going to feel the radial nerve. Okay, so the radial nerve, remember, is in the posterior compartment of the arm, and then it crosses over into the anterior compartment of the arm. It goes between brachioradialis and brachialis muscles. And so right in this area, about 10 centimeters above the lateral epicondyle, you're going to feel something rolling under your thumb, and that's the radial nerve. Okay, so be careful because that hurts if you push on it kind of hard. That's the course of the radial nerve. So now let's take a look on the medial side of the elbow for a second. We're going to use the other arm to demonstrate the medial side for the camera angle. Good, okay. So on the medial side, again, we can start with the olecranon, which is always easy to find, and just moving anterior from the olecranon is the cubital tunnel, and then we see another bone right here. So tip of the olecranon, and then this is the medial epicondyle, opposite of the lateral epicondyle. So between the olecranon and the medial epicondyle is the cubital tunnel, which is where the ulnar nerve lives. So right, my thumb right now is moving over the ulnar nerve between these two pieces of bone. So commonly we say cubital tunnel syndrome, but cubital tunnel syndrome really is compression of the ulnar nerve right here in this one spot. And we know that the ulnar nerve can get compressed above, at, or below the cubital tunnel. So those are different sites. So on the medial side, I look for the olecranon, the medial epicondyle. To test medial epicondylitis pain, you want to be able to palpate the medial epicondyle and just anterior to it. Then you can differentiate between medial epicondylitis pain and pain over the ulnar nerve. So here, I'm going to ask Eileen to make a fist and flex your wrist and ulnar deviate a little bit. So now that activates the flexor pronator mass. The flexor pronator mass is a set of muscles that attaches to the medial epicondyle. And when you have medial epicondylitis, the pain is just anterior to it. When you have ulnar nerve problem, the pain is just posterior to it. Okay, so this is where we tap when we're testing for a Tinel test for the ulnar nerve. So speaking of the ulnar nerve, commonly when I'm testing here, I'll test elbow flexion. So I'll ask the patient to hyperflex their elbow. That puts the ulnar nerve on stretch in the cubital tunnel. And you hold this position for about 30 seconds. You're going to do it bilaterally to compare one side to the other. And if there's a reproduction of numbness and tingling in the little finger and ring finger with hyperflexion of the elbow, that's the indication of ulnar nerve irritation. Tapping the ulnar nerve, the Tinel test, and then palpation of the ulnar nerve to feel if it's tender. The other thing I always like to do is keeping a light thumb on the medial epicondyle, moving the elbow from flexion to extension, and looking and feeling for any subluxation of the nerve. The nerve can subluxate, it can snap forward of the medial epicondyle and relocate again, which can be painful. So a symptomatic subluxation of the ulnar nerve, that's how you feel it. Okay, now, after we've tested all the bony landmarks, then we're going to test the muscles, as I showed you earlier, the biceps, the triceps, the brachioradialis, and so forth. And then we want to do testing of stability. So now we're going to test for varus and valgus stability. So remember, at the medial epicondyle is the origin of the ulnar collateral ligament, and the insertion of the ulnar collateral ligament is going to be at the sublime tubercle of the ulna. So if somebody has a valgus instability of the elbow, the test is done by holding the wrist, holding the elbow, and applying a valgus stress. And you want to compare one side to the other, and I always test it at about 30 degrees of extension. Not full extension and not hyperflexion, but about 30 degrees. And so that's the test for valgus instability. And for varus, it would be the opposite. So it's a stress directed in this direction to test the function of the lateral ulnar collateral ligament, sometimes called the radial collateral ligament as a misnomer. So the ulnar collateral ligament is tested by valgus stress. The lateral ulnar collateral ligament or radial collateral ligament is tested by a varus stress. A simple way to do it in the office is you can ask the patient to do a chair dip. So Eileen, please put both hands here on the rails and just push yourself up like you're doing a dip. So perfect. And so a chair dip can help demonstrate any instability associated with the lateral ulnar collateral ligament. If we can also do a pivot shift test, but that's best done under anesthesia, where the patient is laying supine and you turn the elbow into a knee and you do a pivot shift test looking for LUCL instability. Okay, so let's look at some specific tests when it comes to the ulnar nerve. So for example, on the lateral side, if we're testing for lateral epicondylitis, we can of course palpate the spot as I showed earlier, but we want to do some other tests as well. So here's a wrist extension test. So you can extend your wrist, and I would actively push down on the wrist and then palpate with the thumb at the same time. And what that does is by activating the ECRB and wrist extension, it reproduces the pain at the lateral epicondyle. You can also test finger extension and pushing down on the middle finger. And that test is supposed to be a little more specific for radial tunnel than lateral epicondylitis, but I find that it's also positive in lateral epicondylitis as well. So I typically do both of those tests. And for the medial side, we talked about the palpation of the medial epicondylitis and the flexion and ulnar deviation to activate the flexor pronator mass. So that's a brief examination of the elbow with observation, range of motion testing, checking the ligaments, the muscles, the tendons, and the specific tests. Thank you for your attention.